Welcome, everyone. I'm Noah Reed, Vice President of Sales and Marketing for Precision Analytical, creators of the Dutch test. Thank you all for joining us in this March webinar with our very own clinical educator, Dr. Hillary Miller. This webinar focuses on estrogen metabolism, an often misunderstood aspect of hormonal health. Most people know that estrogen can be the culprit in hormone-related symptoms and that several women's health concerns are impacted by estrogen directly, such as endometriosis and breast cancer. Estrogen symptoms and risks can be impacted by how it's metabolized in the body. This is a practical guide through phase 1 and phase 2 pathways, where key players like P450 and methylation enzymes will be explored. If you're ready to start using Dutch testing in your practice, sign up today as a registered provider. Click the link we've posted in the chat and complete the provider application form. A member of our onboarding team will walk you through the steps to set up an account so that you can begin taking advantage of the education and resources Dutch has to offer. Plus, as a registered provider, you gain access to the Mastering Functional Hormone Testing course, the Dutch Interpretive Guide, and one-on-one consults with Dutch clinical educators like Dr. Miller. This dedicated support and education is designed to help you become the hormone expert. Now, let me introduce today's speaker. Hillary Miller, ND, is a clinical educator at Precision Analytical with 9 years of clinical experience in women's health and fertility. Dr. Miller got her Bachelor of Science in Biology from Portland State University. She completed her medical training at the National College of Natural Medicine, or NUNM, in Portland, Oregon in 2014. At NUNM, she focused on advanced gynecology and women's health and spent 1 year shadowing midwives. Her clinical experience focuses on women's health, including fertility, mental health, weight management, menopause, and anti-aging. Dr. Miller has been a clinical educator at Precision Analytical since 2016. And now, without further ado, let's get today's webinar started.
All right. Thank you, Noah. I'm super excited to get started talking about estrogen metabolism today. So let's just go through an outline of what we're going to talk about. What is estrogen? What are the metabolites? How do we read them on a Dutch test? And what is the research? And what does it say about these ratios? Now, I wanted to give a warning in the beginning of this webinar. In the first maybe 20 minutes, we're going to go through some information that is very quick, okay? We're going to go high level through estrogen metabolism research as well. And hopefully, if you're really interested in these metabolites and you're really interested in these studies, you'll have them there in the references to dive into later. But I'm really going to try to skip through that so that we can slow down once we get to looking at Dutch tests and Dutch examples. And then we can bring in that information that we had before, apply it to what we're seeing. And if you have further questions, I definitely suggest looking in the research. So what does estrogen do, or what is estrogen? It's a female reproductive hormone, although everyone has estrogen at all stages of life. It has significant impacts on many body systems. I'm going to show this diagram because it really demonstrates well how estrogen impacts all aspects of our body, sort of head to toe. We have the brain, the eyes, cognition, skin, cardiovascular health, bone density, then breast and reproductive tissues, the colon it has impacts on, and liver function. Estrogen also has negative impacts on the courses of some diseases, so breast cancer, breast tumors, endometriosis, endometrial hyperplasia, endometrial cancer, and uterine fibroids. These are the top things that we see in medical literature when it comes to the negative impacts of estrogen. And if you'll notice, my point here is that these are in the breast and the endometrium, or the uterus. Those are where estrogen receptors are concentrated, and so estrogen has a really big impact on these tissues. I want to be transparent about estrogen metabolism and breast cancer. most of estrogen metabolism research looks at breast cancer. And I want to make sure I'm transparent in saying that we don't know the full role of estrogen metabolism in breast cancer, although we do see associations. And when we look at risk factors for breast cancer, we're going to see a lot of overlap in estrogen metabolism. So in the US, breast cancer accounts for 30% of diagnosed female cancers, so it's a really big deal. About 1 in 8 average risk women will face a breast cancer diagnosis, and there are a lot of non-modifiable breast cancer risk factors. This means there's many things we can't change that will increase our risk, like age and being a woman. Family history and genetics and ethnicity also account for this, but you can see family history accounts for 15% of diagnoses. That means 85% of women who get breast cancer will not have a family history. Same with genetics, 5 to 10%, but that means 90 to 95% of women will not have these genetics. Modifiable risk factors for breast cancer are smoking, alcohol, BMI, certain types of HRT, exposure to environmental chemicals, low vitamin D, exercise, healthy weight, etc., and breastfeeding before the age of 35. Now, modifiable is stuff that we can influence, which is stuff that we're typically interested in with prevention. And once we get to estrogen metabolism, we're going to see these pop up again. Highlighted in green on both of these lists actually impact estrogen metabolism, and this next list is risk factors for endometrial cancer, uterine fibroids, and heavy menses. So I wanted to hit these lifestyle factors that affect both the breast and endometrial tissue, like I'm focusing on here for estrogen. A little bit different, adequate progesterone here in the endometrium can prevent a lot of, or can prevent fibroids, endometrial cancer, and menses in some cases, heavy menses. We're not going to talk about progesterone and looking at the progesterone to estrogen ratio, and that is really important, but this webinar is really going to focus on estrogen and estrogen metabolism. So how do we assess estrogen levels? Well, we test estrone and estradiol. Usually estradiol is the target since that's the most potent estrogen. Knowing about the timing of estrogen cycles and their appropriate reference ranges is really important, and this point ties into estrogen metabolism later. So I just wanted to make it here so that we remember how important this is later. You can definitely use serum, and of course you can use Dutch urine testing, and we also have cycle maps so that you can see the levels of estrogen over an entire cycle, which is great. One-day test is also great. Yeah. Now we get to our destination. Estrogen production affects estrogen-related symptoms and diseases, but also how we excrete it can affect our levels of estrogen. And that's what we're talking about today. The magnifying glass is our window into the body. So we can look at parent estrogens, phase 1 metabolites, and phase 2 metabolites, along with our patient's history and their symptoms, and we can make an inference to how we can help them. On this slide, I wanted to have an overview of the entire estrogen life cycle. So starting at the top, estrogen can move passively into the cells, and estrogen's actions occur within those target tissues. Phase 1 is a tool that the body uses to deactivate the estrogens in most cases, and therefore control its action. Phase 1 can be problematic, and it seems as though lots of substances can't be fully neutralized in one step. So we see phase 1 being we see phase 1 being problematic with a lot of different substances the body tries to detox. And so it's not surprising that we can have some issues with phase 1 metabolism in estrogen as well. For estrogen detox, phase 1 metabolites have significant oxidative potential, although this varies between the metabolites. Phase 2 takes care of that. So they use methylation and conjugation to neutralize the oxidative phase 1 metabolites, and it also makes them more water soluble for removal through the stool and urine. So here's just a diagram of what we've been talking about, but you can see what we're then measuring in their urine: the methoxy, the hydroxy, and the parent estrogens. Now let's dive into phase 1. So I really love this quote, and this study that I have cited here is a great review, especially if you're new to estrogen metabolism. I suggest you read it because it's really well written, and it explains not only how the estrogens and their metabolites work, but where they work and why they're important. And this beginning quote that I have up here encapsulates everything that they're trying to say and that we're trying to say here. So the cytochrome P450 enzymes, this is phase 1, metabolize estrogens that are expressed in the target tissues. So these are the tissues where we have estrogen symptoms. And they form these hydroxylated estrogens, and these hydroxylated estrogens are right at or near the estrogen receptors, and they can have important biological effects, therefore profoundly influencing estrogen action. And this is how they might impact our patients' symptoms. They're in the tissues, right there with the receptors, acting on their own. So what is phase 1 metabolism? Well, this is an example on the Dutch test of phase 1, and we have the parent estrogens right there. We're following out of estrone. The green pathway is the 2-hydroxy pathway, and this is the happy pathway. The red arrow coming out of estrone shows 4-hydroxy, which is the bad pathway. And we also have a red arrow coming down out of 4-hydroxy that shows why it's bad. It can form reactive quinones, it can become oxidative, it can bind to DNA and cause DNA damage. The blue arrow up top coming out of estrone points to the 16-hydroxy, and this one is estrogenic. So you imagine you have a tissue and it wants to control the action of estrogens, and then it detoxifies them and it's still estrogenic, right? So that can be problematic. The 16-hydroxy metabolites are sulfated for removal, so downstream is also important for phase 1. The 2 and 4 are going to be methylated. And the 2 and 4 are known as catechol estrogens. And this will come up, this word catechol, several times, and it might help you to understand something about the pathways. These catechol estrogens can be oxidized by any oxidative enzymes and metal ions. And the oxidation creates quinones and semiquinones and reactive oxygen species. They'll need to be methylated to be neutralized, but once they're methylated, they are neutralized. And for methylation, we use the catechol O-methyltransferase. So you can see where knowing that they're catechol estrogens helped you understand why they use the COMT enzyme. In the presence of antioxidants as well, the oxidative potential is minimized. So that's going to come up again too. Phase 1 occurs both in the liver, which is probably a lot of what we're seeing in the urine, but it also occurs in the estrogen metabolizing cells. And this leaves estrogen-sensitive tissues vulnerable to the damaging effects of ROS. We'll just review where those are. That includes the liver, but also uterus, breast, cardiovascular tissue, lungs, brain, etc. Now let's look at each of these pathways on their own. The 2-hydroxy estrogens are formed from the CYP1A1 and 1A2 enzymes. We show the 1A1 on the test, but both of those are involved. They're formed in the liver and the target tissues. The 2-hydroxy metabolites are anti-carcinogenic and inhibitory, and although they are oxidative, they're much more stable on their own, as well as being methylated faster. So as you can see, I'm sort of demonstrating that the 2-hydroxy pathway is the happy pathway. We have several articles here which looked at serum and urine samples from women with and without breast cancer that found that greater 2-hydroxyestrogens were associated with reduced breast cancer risk. And again, we don't have time to go into all of the details, but I wanted these to be here for your review later if you're interested. Here's another study. This one is a really interesting read because not all of the studies are consistent about what the metabolites might mean, and Ziegler here gives the history of measuring estrogen metabolites and demonstrates that immunoassays, which were what were used in the beginning of measurement, are not as accurate, especially when we're dealing with very low metabolite levels, as in postmenopausal women. And so the LCMS-MS, which is also what the Dutch test uses, is more accurate, and they demonstrate that these studies get more consistent results. And they also found that higher 2-hydroxy metabolites were associated with reduced breast cancer risk. This study used urinary estrogens, and they measured urinary estrogens and metabolites. They reviewed them in Chinese and American women. Women with breast cancer were compared to controls, but they also compared Asian women to American women, including Asian American women and white Americans. One finding was that higher 2-hydroxy metabolites were found in the controls compared to breast cancer patients, and another was that American women had higher estrogens than Chinese women, and higher parent estrogens were also found in women with breast cancer versus controls. So risks are determined by the action of estrogen and how estrogenic the cells are. And though estrogen is good for our cells need to be able to turn it off. That's what I read out of these studies. Now let's look at the 16-hydroxy pathway. This is the second most used pathway. The 16-hydroxy estrogens are formed from the CYP3A4 in the liver and in the extrahepatic tissues. These are the target tissues for estrogen. It binds and activates estrogen receptors. And some studies show that it has a pretty high binding affinity, and some show that it might be more like E1. So this might depend on the tissue that it's in. Its defining characteristic, though, is that it's more estrogenic, but it's also pro-inflammatory, mitogenic, which would mean proliferative, and angiogenic. And the inflammatory, mitogenic, angiogenic characteristics are all the characteristics of an abnormal cell growth terrain. So the 16-hydroxy is estrogenic, and we know that certain actions of estrogen are really good for the body. We can see that postmenopausal women were found to have better bone mineral density when they had higher 16-hydroxy. So I would not suggest that we support this pathway in postmenopausal women, even though we are always concerned about bone mineral density in this group. I would probably suggest that if your patient was at risk, you would use estradiol, because we still do see that the 16-hydroxy pathway is a little more pro-inflammatory. And so what we're thinking is not pushing this pathway for bone mineral density. We're looking at estradiol and trying to get her to metabolize it through the 2-hydroxy. The 16-hydroxy pathway is also pretty high, although I don't know if it's relatively high in pregnancy. And we don't see increased breast cancer risk in pregnant women. So we want to definitely be transparent that there's some nuance to interpreting the 16-hydroxy. So back again to the Moore study that I talked about Chinese versus American women. They also found that higher 16-hydroxy metabolites were associated with increased breast cancer risk. I mentioned before certain types of HRT might increase breast cancer risk, and this study looked at serum samples from the Women's Health Initiative, and they found a reduced risk of breast cancer in their group of patients who only took estrogens or the conjugated equine estrogens. But they also found a higher incidence of breast cancer in the group that was taking both the estrogens and the progestins. And when they looked at the serum samples, they found that there were higher 16-hydroxy metabolites in the patients who took both the estrogens and the progestins. And so they came to the conclusion that the oral progestins might actually upregulate the 16-hydroxy pathway, and that might be part of the increased incidence of breast cancer that they saw in those groups. So interestingly, this condition, idiopathic pulmonary arterial hypertension, is also associated with increased 16-hydroxy metabolites. So in this condition, high estradiol is known to increase the risk and severity of idiopathic pulmonary arterial hypertension. And I'm going to just call it PAH from now on because it's a lot to say. Men with higher estrogen and postmenopausal women with higher estrogen tend to be at higher risk. However, they have found that estradiol is protective to the cardiovascular system, including in these patients with PAH. The women women do have higher survival rates than men, and estradiol inhibits the inflammation in the cardiovascular tissues. But the serum 16-hydroxy metabolites appear to increase inflammatory cytokines and again be angiogenic and mitogenic, and this increases this sort of abnormal cell growth, which might contribute to negative or poor outcomes with arterial health. Rheumatoid arthritis and systemic lupus erythematosus are two autoimmune diseases. 16-hydroxy metabolites are significantly increased in the urine of patients with these diseases. And it was found that the SLE autoantibody binds to the 16-hydroxy-E1 metabolite. So that metabolite might actually be stimulating this autoimmune process. SLE and RA have also both been associated with PAH from the previous slide. So there's probably a tie-in there with 16-hydroxy. Now, in endometriosis, which is a case that we get a lot of questions on for 16-hydroxy metabolites, we don't have any direct outcome studies or association studies with measuring 16-hydroxy metabolites in these patients, but this study shows that the CYP3A4 enzyme is significantly higher in endometriotic lesions, and that can increase the estrogenic activity of these tissues, or maybe it's the pro-inflammatory and proliferative effects. So now let's look at ratios, and I just want to explain the math behind a ratio for a second, just so we're all on the same page. The ratio helps us understand what metabolite is dominating, even when estrogen levels are changing. So estrogen levels change throughout a cycle, and they change throughout a woman's life. So which one is most prevalent in the woman at all times? With the 2-hydroxy on top of the ratio, that means that a higher ratio equals more 2-hydroxy or less 16-hydroxy. Therefore, we're going to say that a higher ratio is probably better because 2-hydroxy is associated with fewer risks than 16-hydroxy. So this study looked at the 2-to-16 ratio, and they found that it was higher in controls compared to breast cancer patients or high-risk women, so women who had a high risk of breast cancer. And here is another study where you can see that the control group had a higher ratio of 2-to-16 compared to breast cancer patients. Finally, this study looked at urine samples collected after a breast cancer diagnosis and compared to control patients. Urinary estrogens and their metabolites were measured, and they found a lower 2-to-16 ratio was associated with higher all-cause mortality, especially in breast cancer patients. And a higher 2-to-16 ratio had a lower risk of mortality, especially from breast cancer or cardiovascular disease. Now let's talk about the 4-hydroxy pathway. 4-hydroxy metabolites are formed from the CYP1B1 enzyme in the liver and target tissues, and it has some binding affinity for the estrogen receptor. So once again, we're in the cells trying to neutralize and remove estrogens and estrogenic activity, and we're maintaining some binding affinity and activity. So maybe there's some, maybe some of that is okay, but it's probably not ideal if you're trying to detox. But the defining feature of 4-hydroxy is that it's unstable and it forms reactive or oxidative quinones, and these can bind to DNA and cause damage. The 4-hydroxy E1 is also slower to go through phase 2 methylation than 2-hydroxy, so it's slower to be neutralized. Here in this graph, the first 2 columns, or the first 2 sections, show tissue from mammary fibroadenomas and adenocarcinomas. And then the third one shows normal tissue from women with a history of breast cancer. And the final one shows normal tissue from women without a history of breast cancer, just from regular biopsies. And the white bars show the 2-hydroxy E2, and the black bars show the 4-hydroxy E2. And you can see the 4-hydroxy is higher in the fibroadenoma and the adenocarcinoma tissue. And the 2-to-4 ratio is a lot closer in the normal tissue of patients who had a breast cancer history. So they're a lot more equal, is what I'm saying. And then in the patients without a breast cancer history, they had more 2-hydroxy to 4-hydroxy. This study found an increased risk of invasive breast cancer in patients with higher unconjugated serum estradiol, so higher active estradiol, and in patients with a higher 4-hydroxy over 4-methoxy ratio. So that means that more 4-hydroxy in those patients was associated with invasive breast cancer. And they also found that patients with higher 2-hydroxy metabolism had lower risk. This study looked at a few things, so I'll just go through the conclusions that they found. They looked both in women, human metabolites and human samples, and then they looked at petri dishes and mice. So 4-hydroxy metabolites were increased in women with breast cancer compared to controls, and 4-hydroxy metabolites induced malignant transformation and tumorigenesis in nude mice. 4-hydroxy metabolites were found to have compromised the spindle assembly checkpoints. So if you remember back to cellular mitosis, we want those checkpoints so that we don't replicate cells that are bad and are not functioning very well. And this is a mechanism for carcinogenesis. And then they took transgenic mice. So they had genetically increased their CYP1B1, and these mice developed mammary cancer. This study is pretty interesting. They took urine samples and lung tissue samples from healthy controls and from patients with small cell lung cancer. And what they found is 4-hydroxy metabolites were higher in the small cell lung cancer tumor tissue versus normal lung tissue, and they found the same pattern in urine. In a 2014 study of urinary estrogen metabolites and BPA, in Korean adults, higher BPA was associated with higher 4-hydroxy metabolites and higher parent estrogens. Breastcancer.org talks about BPA having weak estrogenic activity, and that perhaps if you have breast cancer, you want to have less BPA, but it also on its own increases the risk of some other cancers. Now that we talked through phase 1, we're going to talk through how phase 2 happens and how problems with phase 2 might influence phase 1, and therefore some of our risk factors for phase 1. Yeah. So the COMT enzyme, or catechol O-methyltransferase, it methylates the catechol estrogens, the 2 and the 4-hydroxy. And low COMT activity has been associated with increased catechol estrogens. So it sort of, if you can't go through phase 2, you can back up and leave these catechol estrogens hanging out for a longer time. And if you remember when we talked about it, The catechol estrogens do have oxidative potential, especially the 4-hydroxy. And so when they back up and they're hanging around for a longer time, we have a higher potential for oxidative damage, cellular damage, DNA damage, and all of those things that we don't want. Slow COMT activity has been linked to endometriosis, endometrial cancer, breast cancer, and uterine fibroids, although there's mixed data on the fibroids, which I'm going to talk about in a second. So essentially, COMT deactivates the catechol estrogens. By deactivating them, it prevents them from causing DNA damage. And if the COMT is not working well, we can have a buildup of these 2 and 4 hydroxyestrogens and any of their negative impacts. So there's a set of common polymorphisms in the COMT enzyme, as many of us probably know. The Val158 MET, or I'm going to call it Val-MET, is associated with slower activity than the wild type. And a meta-analysis of studies looking at COMT polymorphisms found that this Val158 MET was associated with breast cancer susceptibility in Asian women. There are several studies on COMT genetics and uterine fibroids, and we do have some mixed results. The Val158 MET polymorphism is both associated with an increased and a protective impact on uterine fibroids. So we want to make sure that we're careful if we're going to try and only influence COMT activity, which we don't recommend here, when a patient has uterine fibroids. So the point that I want to make here is that the literature is mixed, but one study found that green tea extract protects against and can shrink uterine fibroids, in part via reduced COMT activity. And I want to circle back to phase 1 estrogen at this time. These metabolites are oxidative, and our concern with COMT is that we want to remove the oxidative metabolites from phase 1. Well, if giving green tea is extremely antioxidant, which is one of the mechanisms that they think it helps fibroids, then maybe it takes care of some of the jobs that COMT is meant to do by reducing the oxidative metabolites in the system. So it's a little bit of a walk around to make sure you understand that, but that's where green tea can slow down COMT, but also protect against phase 1 issues. So the COMT enzyme basically is an important final step in estrogen detoxification, and it works on the 2 and 4 hydroxy metabolites, and it reduces their oxidative potential. Green tea slows COMT, and it's a powerful antioxidant. So the point of talking about COMT in this way is to say there are multiple ways that we can help phase 1, and COMT is one of them. Another point is that fast COMT activity has not been associated with estrogen-related health issues, and we do see fast COMT coming up on the Dutch test. We get a lot of questions about if that is problematic or not. We don't see any evidence that it is, but just remember on the Dutch test, we're only looking at estrogen metabolism. Slow COMT activity may not be a serious risk if the patient is healthy and has good antioxidant status. So let's look at an overview of estrogen metabolism. The CYP1A1 makes the 2-hydroxy metabolite, and this is our happy pathway. It has low estrogen receptor binding affinity. It's oxidative, but it's stable, and it's been found to be non-estrogenic, anti-estrogenic. It inhibits cell growth and proliferation, and it's rapidly cleared by the COMT enzyme. The CYP1B1 is estrogenic, but it's mainly known for its potential for DNA damage and reactive oxygen species. It makes the 4-hydroxy metabolite, and it has estrogenic and genotoxic effects, and it's slower to be cleared by the COMT enzyme than the 2-hydroxy. The CYP3A4 makes the 16-hydroxy metabolite, and it's known for being estrogenic. It has a moderate to high estrogen receptor binding affinity. It's inflammatory, mitogenic, angiogenic, and proliferative. The COMT enzyme makes the 2-methoxy and 4-methoxy metabolites. These inhibit carcinogenesis. They have low to no estrogen receptor binding affinity, and they are stabilizing and neutralizing for the phase 1 metabolites. Now let's go back to our modifiable risk factors. Now that we've talked about estrogen detox, I wanted to go through a list of related items. Alcohol, what I have in blue here, alcohol consumption, sedentary lifestyle, and obesity have all been associated with higher 16-hydroxy metabolites, and they're also associated with higher risk of breast cancer and endometrial cancer and endometriosis and uterine fibroids. And tobacco use is associated with higher 4-hydroxy metabolites. So we can see these things can impair healthy detox, and they're also associated with negative health impacts of estrogen. And then supporting healthy detox, we typically focus on the 1A1 pathway, just going down that 2-hydroxy pathway more. This is done via sulforaphane and cruciferous vegetables, resveratrol. We also have glutathione in green tea and rosemary. Now, I've highlighted in green those ones that promote greater 2-hydroxy metabolism. We've also seen these have beneficial impacts on breast cancer risk in some studies. And then the glutathione and green tea are antioxidants. So I also showed that they do, although they don't promote more 2-hydroxy metabolism, they help us resolve the oxidative potential of the phase 1 metabolites. Now, how do we measure estrogen metabolism? A couple of philosophical points, and then we'll get into some examples. So estrogen metabolism is commonly measured in ratios because there are large variations in estrogen levels, and these ratios help us understand which metabolite is more prevalent regardless of the levels. Now, I've given an example here where we have a woman's estradiol throughout her entire cycle. And if you look at the gray background versus her results in green, you can see that she does follow the pattern, but she doesn't hit her peak estrogen at the same time as it would be expected. Now, most women follow the pattern. Hers is a little off. Imagine if you measured her 1-day Dutch test on day 19. In hers, her estrogen would look very high for a luteal phase, but she's probably actually in her ovulatory phase. So you see very high estrogens. And if you look at her metabolites, they're going to be high as well. But if you look at them in a ratio, you can probably see her dominant pathway. And that's going to help you make better decisions for her, because as we can also see, if we look at her estrogens across the cycle and we take all the different phases into account, she doesn't actually have high estrogens. So really, ratios can help us control for these varying levels. The metabolite actions are also not isolated, so the 2-hydroxy and the 16-hydroxy might be made in the same tissue, and the 2 is anti-proliferative and the 16 is pro-proliferative. So looking at them in ratios tells us which one dominates and which is possibly influencing your patient's symptoms. Now, we do want to say that if you measure your patient's 4-hydroxy and it is high, or their 16-hydroxy and it is high, we're not saying that you shouldn't address that if the ratio is good, but we need to take all of these pieces into account. We also follow estrone metabolism when we're looking at estrogen metabolism. This is because estrone is more abundant at all stages of life, and this is especially important in postmenopausal women. Stable ratios are found in numbers that are more abundant, basically. And much of the research we have follows the estrogen metabolism due to its abundance. At Dutch, we found that the E2 metabolism ratios vary more day to day than the E1 or the estrone metabolism, and the stable ratios are more clinically reliable. So if you measure your patient's estrogen metabolism on one day and it's prone to changing every day, then that's not something you want to base a clinical treatment plan on. So just a quick start before we look at cases, the steps to measuring estrogen metabolism are as follows. We look at the parent estrogens. Of course, the level of parent estrogens matter. Then we follow estrogen metabolism for the reasons I've just explained. Then we look at population ranges for the metabolite levels, and then we look at the ratios. Now let's look at some examples. So this first set of examples that I have here is a single woman who measured her full Dutch several days throughout the same cycle. And on the first set of an example, we have high estrogens, and the middle we have low, and at the end we have medium level estrogens. And if you just take a quick glance at her pie chart and her methylation fan gauge, you can see she's getting almost the same result on the ratios despite the very different levels of estrogens that she has. So even while the estrogen levels are fluctuating, her metabolite ratios are stable. That's what we want for clinical treatment plans. So now let's start by looking at a case. Now this is a premenopausal 41-year-old female, and she's not reporting significant estrogen-related symptoms. In fact, her testing appears to be centered around adrenal and androgenic concerns. So she's got some anxiety is one of them. Her parent estrogens are normal, and that makes sense. She doesn't have a lot of estrogen-related symptoms. Her phase 1 metabolites are pretty healthy. We see her pie chart is dominated by the green, which is the 2-hydroxy pathway. Her actual 2-hydroxy is in a very normal range, and the 4 and 16 are low, which is fine. She's a slow methylator. Although the slow methylation doesn't appear to be causing a lot of 4-hydroxy buildup, she is still a slow methylator. And her 2-hydroxy is okay too, so it looks like this is possibly not bad for her estrogen levels. However, her complaint was anxiety. So we do want to point out that although we're only measuring estrogen levels here, COMT activity does also affect catecholamines, right? It's a catechol O-methyltransferase that methylates the catechol estrogens. And so catecholamines are stimulating neurotransmitters. She may also be slow at breaking down her catecholamines. So just a brief note, COMT is really supported by magnesium, B6, B12, folate, choline, methionine, and trimethylglycine. And that might be something that she could address, and we might see a change in her anxiety from that. Although the Dutch test does look at her cortisol, which we're not going to look at today, and so there would be a lot of other ways to look at causes of anxiety for her. So I just wanted to review this point that COMT also methylates catecholamines. This was a pretty normal case, and now we're going to look at some differences. So this is a 28-year-old cycling female with endometriosis. She has a great diet and lifestyle, and she has started to have significant endometrial pain with her menses. So she came in to try and figure out what else she could do to help herself. If you look at her test results and her parent estrogens, you can see they're low. And I wanted to use this case as an example because we get a lot of questions about how can a patient with endometriosis pain have low estrogens? Well, we do see it. Estrogens being higher definitely can make that pain worse for some patients, and so that's a modifiable risk factor we can look at. But if estrogens are low, looking at the metabolism might give us more insight. Her pie chart reveals a strong 16-hydroxy preference. And if you look at her pie chart carefully, and we'll show it a little bit closer in a moment, her 4-hydroxy looks like it's in range for its relative percent. But if you look to the left, you'll see we have these sliders. I'm using these sliders today because separating out the metabolites and comparing them to the 2-hydroxy is also important. Because she has such low 2-hydroxy, her 4-hydroxy might be more dominant in her tissue, even though it's in a normal range. So we want to take these out separately, and the pie chart can be a little bit deceiving when there's a lot of 16-hydroxy. The 4-hydroxy can look more normal, but if you see that the 2-hydroxy is low like this, then you may also consider that the 4-hydroxy might be dominant. Now, she's a really good methylator, so let's follow the case for a little bit longer for another point. So her initial report we did treat with DIM. DIM is a cruciferous extract that really powerfully promotes the 1A1 pathway. And in fact, it promotes it so powerfully it can lower E1 and E2. They sort of just get sucked down that pathway. Usually, I only use DIM if I want to lower E1 and E2, and in most cases, when I saw levels like this, I probably wouldn't use it. But since she had endometriosis and significant pain, I decided that lowering her parent estrogens might be a good idea. But after introducing DIM, she got a new symptom. Along with improvement in her endometriosis pain, she developed vaginal dryness. So we decided to remove the DIM and focus on ground flax, organic soy foods, and sulforaphane, which is much gentler. And her endometriosis pain remained improved, but her vaginal symptoms returned to normal after we got rid of the DIM. So looking at the 2 to 4-hydroxy independently was helpful for her case to see it was also out of balance. And I will also add in, which I didn't say before, 4-hydroxy being oxidative. Oxidative stress is a major component of endometriosis pain. So definitely using more antioxidants might have been helpful for her too. Her 16-hydroxy may be associated with estrogenic symptoms, even if the parent estrogens aren't high. And the final point, DIM powerfully activates the 2-hydroxy pathway, which can lower estrogens, and this may not always be desirable. Okay, next case. This is a 52-year-old postmenopausal female with hot flashes, night sweats, and vaginal dryness. Her pie chart shows she has high 4-hydroxy metabolites, and her methylation is fast. So although her actual 4-hydroxy, if we look at her dial, isn't high, she compared to premenopausal females, for example, she wants to raise her estrogens using hormone replacement therapy because she's having low estrogen symptoms. And so if you can imagine, if we raise estrogens and she has a relatively high 4-hydroxy, she's going to be prone to going down this pathway much more. She's also very close to higher 16 on her when we isolate out her 2 to 16 ratio, although she's still well within the green, so we're probably not going to worry about that. Because her methylation is fast, supporting the 2-hydroxy pathway while considering hormone replacement therapy might be a good idea. Another possible approach if you give her HRT is to make sure she has lots of antioxidants so that she can neutralize the oxidative potential of 4-hydroxy. So let's just review. Consider the potential of her low metabolites to cause harm. A lot of the studies we looked at did use postmenopausal patients. So even low metabolites may cause harm. But if we're going to add in HRT, just remember those metabolites will increase. And then considering the impact of DIM, so DIM isn't the only thing we can use to push the 2-hydroxy pathway. We can also use cruciferous vegetables, ground flax, and soy. And we can use antioxidants as well to improve phase 1 and phase 2 detox. Now we have another tricky case. This is a 40-year-old female. She is cycling, but her cycles are irregular. She has high estrogen symptoms, which means for her fibrocystic breasts, mood swings, and heavy menses. If you look at her pie chart, her 16-hydroxy is high, And actually, if you look at both her 2-4 and 2-16 balance, you can see that she's favoring the 16 and the 4-hydroxy for both of those. And the 2-hydroxy is low. Her parent estrogens are low. This is probably because we caught her in the wrong time of her cycle because she's irregular. And having low parent estrogens at this time is not a big deal. We don't necessarily need to do a full Dutch test a second time at the right time in her cycle because we know her pie chart and her methylation gauge are consistent throughout the cycle, or they are for most patients. And her symptoms do fit high estrogens. So she has a healthy phase 1 metabolism. We might consider supporting the 1A1 pathway, and for her, possibly using DIM is okay. Since her cycles are irregular, she might have high estrogens at another time in the cycle. This might be a good case to run a cycle map for because it's hard to find when she's having a luteal phase or when the right timing is for her one-day test. But you could also go ahead and assume she has high estrogens, or you could use gentler support to improve phase 1 and see how it goes. So in patients with irregular cycles, I'm just going to repeat this, metabolite ratios are still accurate even if samples weren't collected at the right time. If her 2-hydroxy is low, a careful review of her parent estrogen levels compared to phase 1 metabolites can help. And separating out the 2-4 and 2-16 ratios can help you see how strong her preference is for one side or the other a little better sometimes. So now we have some treatment considerations, and I want to talk through the philosophy of treating phase 1 metabolism and also phase 2. We have a lot of this information in our steroid pathways, which is a really helpful resource, but it doesn't tell you everything about what you should do with that pathway. So when we're thinking about phase 1 estrogen metabolism, we have to remember that these metabolism pathways are still detox pathways. So even though we don't like 4 and 16 hydroxy, we don't want to block those pathways because those metabolites are also possibly detoxing other things in our body. So the basic approach is if 2-hydroxy is not adequate or another metabolite is dominating, then supporting the 1A1, the healthy pathway, is the safest way to approach it. This is typically done with cruciferous vegetables if you want to be gentle, or DIM if we have high estrogens on board. And then this list, caffeine, soy, fish oil, flaxseed, etc., is a great list. We have all the resources to look into these studies in the back. With the 3A4 pathway, I also want to point out that this pathway metabolizes a lot of drugs. So if your patient is on any medications, you might want to make sure before influencing this pathway that you're not going to influence how their medication is detoxed. Many providers probably know that there are certain drugs that give you a warning about not drinking grapefruit juice, for example, while you're taking that drug, because it can cause problems with how the drug is metabolized and actually raise how much drug is in your system, possibly too much. And then our CYP1B1 here, you can see that things that increase it are things that we don't want anyway. And I just want to point out PAH in this table actually means polyamino hydrocarbons, where we used it earlier in the presentation to mean pulmonary arterial hypertension. COMT enzyme, we reviewed this, magnesium, choline, B6, B12, folate, betaine, and trimethylglycine. And our Dutch interpretive guide is a really useful tool for looking at estrogen metabolism as well. So click the link in the chat to become a provider, and then you can get access to our Dutch interpretive guide. So let's just go through a summary of estrogen metabolism really quick. Estrogen is a powerful hormone. It has tons of health benefits, but if it hangs around or is too high, it can also have negative impacts. You can increase the risk of breast cancer, for example, heavy menses, increase the severity of endometriosis and uterine fibroids. So detoxification of estrogen is an important step in regulating estrogen levels. Phase 1 detox has 3 pathways. The 2-hydroxy pathway is protective. The 16-hydroxy pathway is proliferative and estrogenic. And the 4-hydroxy pathway is genotoxic and oxidative. Phase 2 detox neutralizes phase 1 metabolites. The COMT enzyme methylates catechol estrogens, the 2 and 4-hydroxy. And conjugation is also a neutralizing phase 2 pathway, such as the sulfation on the 16-hydroxy. Measuring estrogen detox, you want to follow the estrone pathway, use both the levels of metabolites and the ratios of the metabolites. And then the important ratios you want to look at are the 2-4, the 2-16, and then of course the pie chart that we have, as well as the 2-methoxy to 2-hydroxy. And the ratios are seen, of course, in the pie chart and the methylation gauge. Thank you so much for letting us talk to you about estrogen metabolism today. Hopefully you've gotten a really good feel for how to read it and what these metabolites mean. Okay, unfortunately we don't have enough time for questions today, but if you follow us on Instagram at Dutch Test, we may be able to answer some questions there, or you can email us info@dutchtest.com.
Thank you all for joining us today. Watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. You can learn more about the research behind the Dutch test at dutchtest.com/research. And make sure you visit the Become a Provider tab at dutchtest.com to register for an account so that you can gain access to even more hormone education and research. Don't forget to follow us on Instagram at Dutch Test for more hormone education, tips from our clinical experts, and more.